Well, good afternoon. This is still chapter 6 of the textbook of radiographic positioning and related anatomy, the 11th edition. Today we are going to look at the tibia and the fibula, sometimes referred to as the lower leg. Um, as we said before, we are breaking this chapter down into smaller pieces so that it's a little more attainable and easier to follow and not have to listen to a 3 hour lecture just to understand the positioning of this. So, tib fib is going to be in chapter 6, and when we start with the anatomy, again, remember that this is in the front of the chapter. This is actually referencing the picture on the very first page of the chapter, 212, figure 6.1. And so far, we have looked at positioning for the toes, the foot, the calcaneus, the ankle, and now we are on tibia and fibula, so the lower leg. Okay. When we look at the anatomy of the tibia and the fibula, we can reference the page that this picture is on is page 218. All right, and this is looking at the tibia and the fibula from the anterior view. So this is figure 6.17 on 218. All of this information here that's listed up here, all of these are very important. This is very similar to the forearm where we have the radius and ulna. Okay, so some of the information on here, we have the anterior crest, which is right here. That's that ridge along the front of your leg. Sometimes if you hit it, it can be extremely painful on there. They don't have labeled, but it would actually be right here. We can go ahead and highlight that. Let's highlight that with purple. Right here, this is the tibial tuberosity right in the front there. Okay. Some of the other anatomy on here, anterior crest, we have the articular facets at the tibial plateau up here. All right. We have the body of the fibula right here, the fibular notch, fibular notch down here on the tibia, the intercondylar eminence, the medial and lateral intercondyloid tubercles are up here. The tibial plateau is this whole thing right up here. Um, the lateral condyle, is right here, and then we have the medial condyle right here. So this is where the knee joint would be formed. We have the lateral malleolus right here, even though it's not really identified. And then we have medial malleolus over here, medial condyle. I'm not sure what this is referencing. Maybe I was just listing them all, or maybe it just came in like that. But tibial tuberosity is not labeled, but this is where that would actually be. Okay. If we look at this anatomy in a lateral view, right, this is on 218 as well, figure 6.18. And um, I want to let you know that this tibial plateau right here, this that they're looking at and showing you the 10 to 20 degree angle, is extremely important. It slopes posteriorly. So this is the front of the patient. This is the back of the patient. If we look at this on page 218, if we look at the figure 6.18, they do reference that the upper articular surface of the condyle has two smooth concave articular facets. That is the tibial plateau, and that articulates with the femur to form the knee joint. And when we look here on this lateral view, notice that the articular facets that make up the plateau slope posteriorly from 10 to 20 degrees in relation to the long axis of the tibia. Now, why do we care? This is important because when we do an AP knee, the central ray has to be angled in relation to the IR and the tabletop in order to be parallel to the tibial plateau. And that angle is essential in opening the joint space on an AP knee. So this is what we're talking right here. This posterior slope of 10 to 20 degrees, that is what determines our angle on an AP knee. Now, granted, we're doing tibia and fibula, but when we get to that, the degree of angulation is determined by the patient's measurement of their thighs, their hips, basically. So determining how what that measurement is and whether to angle cephalic or caudal is important. And so the answer to the reason what is the reason that we angle on an AP knee is not to open the joint space. The answer to why do we angle on an AP knee is to be parallel to the tibial plateau, which in turn opens the joint space. Okay, so we angle on an AP knee to be parallel to the tibial plateau, which then opens the joint space on an AP knee. So that relationship right there is extremely important. When we look at the fibula is a non-weight-bearing bone. You've got the apex of the fibula, the head and the neck. Then you have the body or the shaft of the fibula. And at the distal portion, we have the lateral malleolus. On the tibia, on the inside, we have the medial malleolus, the body or shaft, and then we have the tibial plateau up here. All of that is found on page 218. When we look at the anatomy radiographically, we can find this on page 222. I've gone ahead and filled in the letters for you. So A is referencing the medial condyle, B is the shaft or the body of the tibia, C is the medial malleolus, D is the lateral malleolus, E is the body or shaft of the fibula, F is the fibular neck, G is the fibular head, H is the apex of the fibula, I is the lateral condyle, and J, right in here, are the intercondylar eminences, both of these little tiny two peaks on there. All right, and that is an AP right tibia and fibula. How do I know that? Because in that particular view, if it's an AP, the fibula sits lateral, and the only way that the fibula could be on that side of the patient, if I'm looking at them, is if it is a right tib fib. If we look at this anatomy in lateral, this is also on page 222. I have filled out the anatomy for you as well. So A represents the intercondylar eminences up here. B is the tibial tuberosity. That's what I drew for you in purple on a picture a few slides back. So that is the tibial tuberosity. C is the shaft of the tibia. D is the shaft of the fibula. E is the medial malleolus, and F is the lateral malleolus. All right. When we look at the joints of the lower limb, we do have the patellofemoral joint, which is between the patella and the femur. We have the knee joint as well, which is between the tibia and the femur. We have a proximal tibiofibular joint and a distal tibiofibular joint. That's what allows you to rotate the bones in your foot, just like the radio-ulnar joint in the forearm. We have a proximal radio-ulnar joint and a distal radio-ulnar joint. We also have the ankle as a joint in the lower limb, intertarsal joints, tarso-metatarsal joints, metatarsophalangeal joints, and interphalangeal joints. All of those are part of the lower limb. If we move on to looking at the imaging of the tibia and the fibula, they are long bones. So remember that long bones require imaging to include the joints at both ends on especially initial imaging, as we've talked about before. But on follow-up imaging, like if you were following up with an orthopedic after diagnosis of a fracture or something along those lines, then at times it is possible that you only include the joint closest to the site of injury. But on initial imaging, you always need the joints at both ends of the long bone. So AP tib fib is on page 245, okay, or AP lower leg. Sometimes they will reference it as that. And you can see on this particular slide we have two images. We have one with the image receptor placed portrait to the lower leg, and they are attempting to fit both the knee joint and the ankle joint on one IR portrait. I will tell you that most adults will not fit with both joints on one IR portrait. So what we usually do is we can turn the IR diagonal and we can go from corner to corner to get the joints. So if you go from top to bottom, we know that that image receptor is 17 inches in length. But when you go from corner to corner, you end up gaining about 4 inches. It's just a little over 21 inches when you go from corner to corner to capture that image. So if the patient does not fit like this, instead of doing two separate images, you do have the capability to turn the image receptor diagonally and capture both joints. So on this image, they're showing you with these black dots, that's the ankle joint, that's the knee joint, and yet you're getting them both on one IR. When you look at it like this, they're telling you you're extremely close to missing the knee and the ankle joint, so you're better off to turn the image receptor. Okay, so on this, we're going to have the leg in a true AP position. Central ray is just like it was for forearm. It's going to be midpoint of the tibia and fibula, so midway between the knee and the ankle. Typically, like we said, adults is on a diagonal image receptor. And if you place the IR diagonal, you do have to raise your SID between 44 and 48 inches to reduce divergence of the beam and include more of the body part. Okay, so if you go diagonally, then you're going to raise your SID to at least 44, possibly 48 inches to reduce the divergence of the beam. Your technique is 70 kVp at 2 MASH, just like it was for an AP forearm. If done appropriately, I will show you one other picture that's showing you what it looks like on the IR diagonally. You can see that the central ray is midway between the knee and the ankle, so right there, and then marker should go lateral to the part, and that is ideally what it would look like on there. All right, on the image itself, you do have to include the entire tibia and fibula with both ankle and knee joints. Okay, the patient was lying on their back for that, and like we said, on a follow-up exam, it may be necessary that you only get the joint closest to the site of injury. You don't have to necessarily include both joints, but it totally depends on what you're imaging for, who the physician is. A lot of orthopedic docs don't require both joints. Some only require the joint closest to the site of injury. The other view that, I'm sorry, so if we look at this radiograph, we can see the entire tibia on here along with the fibula. You definitely have the ankle joint included, and we definitely have the knee joint included. Notice it says there's partial superimposition of the fibula and tibia at the proximal and distal ends, so right up here and right down here. But that is a really nice AP tib fib. Next, we would do a lateral, and we do a medial-lateral projection, just like all the laterals we've done so far have been medial-lateral as far as our extremities. Fingers and toes a little bit different, but for foot, calcaneus, ankle, tib fib, all medial laterals. Again, the central ray is to the midpoint of the leg. We're raising or leaving the SID between 44 and 48 inches to capture more of the anatomy. You can see that this IR is diagonal. And notice it says you have to be capturing at least 1 to 2 inches beyond each joint. So you can see the patella here, which means the knee joint is probably right here, and they're definitely capturing more. And we can see medial malleolus here. So I'm sure they have both joints on there. Their SID would be a little raised from between 44 or 48 inches. They're using 70 kVp at 2 Mass. And if that image is done correctly, then again, they will get the entire tibia and fibula demonstrated. The knee and the ankle joints will also be on there. The proximal head of the fibula is superimposed by the tibia, and the distal fibula is superimposed over the posterior half of the tibia. This is actually a really nice lateral tib fib, and ideally this patient was not a trauma patient. So we'll talk about that next, even though we don't have the images to go with that. If the patient was a trauma view patient, we would do our AP just like we had imaged on 245. But for the lateral, instead of rolling the patient into a medial lateral projection, we could just leave the patient in an AP, and we could move the beam to be a horizontal beam, and that would be considered a cross table lateral. If you look on page 246, they do reference a horizontal beam or a cross table lateral. If the patient could not be turned, that can be taken cross table with the IR placed on edge between the lower legs. You would place a support to hold the IR in place and direct the beam horizontally from the lateral side of the patient. They do show you an image on figure 6.102 of a cross table lateral. So there's really no difference except that you're not rotating the patient to achieve that. You're actually using the beam and going across the table and achieving a lateral position. So a cross table lateral, remember we've talked about before, horizontal beam. Typically when we think that, we think because we are looking at air fluid levels, but on extremities, when you shoot cross table, you're typically doing it so that you don't have to roll the patient into a possibly painful position and or a position that will ideally or could ideally injure them further. So you would evaluate the AP and then possibly do a cross table lateral for trauma views. That brings us to the end of the slide. What we are doing is just shortening these so that they're in smaller chunks that make them more attainable. So this was just tibia and fibula. 2 bones make up the tibia and fibula, 2 views for a tibia and fibula. If you have any questions or comments or concerns, please make sure to note those, and the next time we meet in class, we can address those and go over anything that might be concerning to you. But until then, I hope you watch the positioning videos that are up, and I hope you have a wonderful rest of your evening.